Procalcitonin is a very valuable marker in the antibiotic stewardship program because of its ability to distinguish between viral and bacterial infections, to forecast the severity of a bacterial infection, and also declining levels can be used as the endpoint for antimicrobial therapy, thereby decreasing the duration of exposure to antimicrobials. It's a peptide, 116 amino acids in sequence, and is secreted by the parafollicular C cells of the thyroid in the normal state. It is a precursor to calcitonin, which is involved in calcium homeostasis, and it is believed procalcitonin has a role to play in the inflammatory response to infections. In the presence of an infection, there is extrathyroidal synthesis, especially bacterial, and the sites are lungs, liver, pancreas, kidney, and intestine. The production is induced by endotoxins and cytokines and chemokines, and the most remarkable of which is the lipopolysaccharides, which are a constituent of gram-negative bacteria. And generally, the elevation in procalcitonin is very remarkable in severe gram-negative infections as compared to gram-positive infections. The levels can rise as much as 100 to 1000 times, so there is a lot of discrimination between what is normal and what is abnormal. The usual cutoff for procalcitonin is taken as 0.1 milligrams per ml, and the beauty is that it rises within 3 to 6 hours of an infection. So one of the earliest markers which could be indicative of the presence of an infection. Compare that to CRP, which takes a much longer time for a rise to show. Elevated procalcitonin levels can be a pointer to bacterial infection, and higher levels are associated with worse illness and septic shock. On the contrary, declining levels are suggestive of response to therapy, and that is why serial measurements are useful as part of antimicrobial stewardship and looking at progress of the patient along with the clinical parameters. It can distinguish viral from bacterial infection, and interestingly, gamma interferon, which is released in viral infection, actually suppresses procalcitonin level, so there is no appreciable rise of procalcitonin in the presence of viral infections. There is some amount of elevation of procalcitonin in fungal infections, but it is very limited. So levels above 5 milligrams per ml have a good negative predictive value. So once the levels exceed this, you're almost sure that probably there is a bacterial infection which is the cause for the elevation in procalcitonin. The half-life is around 1 day, and since it does not undergo further metabolism once it is produced, a 50% decline in 24 hours suggests good response. And that is how we can serially do procalcitonin, maybe at 24 to 48 hours, to look at the response to therapy. A total 80% total decline from baseline or an absolute value below 0.5 in sepsis and 0.25 in pneumonia could be taken as endpoint for therapy. And this has been proven in numerous trials that if we use procalcitonin as a marker and serially follow, we can cut down the duration of antibiotic therapy as opposed to when we do not use it. So you can have clinical endpoints or you can have procalcitonin endpoints to discontinue antimicrobial therapy. Other than bacterial infections, common causes for procal elevations are chronic kidney disease, congestive heart failure, post-cardiac arrest status, major abdominal and cardiothoracic surgery, burns, trauma, carcinomas, cirrhosis, immunomodulator therapy, and in neonates up to 48 hours where different cutoffs are used. It can be elevated in pancreatitis, and higher levels are associated with more severe disease. It can also be used in pancreatitis to tell us about the presence of a superadded bacterial infection. So maybe a baseline procalcitonin can tell us about the severity of the pancreatitis, and then serial levels may tell us the point where there is a complication of pancreatitis with bacterial infections. One important utility is in COAD exacerbation, where procalcitonin may help in deciding on antimicrobial therapy. We need to understand that patients with COAD frequently have exacerbations and are treated with antibiotics both on OPD and inpatient basis, exposing them to recurrent rounds of antibiotic. Almost for every exacerbation, empirically antibiotics are prescribed. And to protect these patients from repeated prescriptions of antibiotics, we can use procalcitonin. And you can use a cutoff for deciding on whether antimicrobial should be given in COD exacerbation or not. No marker is as valuable as procalcitonin for antibiotic guidance, and this has been there for 2 decades and more now, and we will continue to use it as part of our antimicrobial stewardship program.